I am very excited to introduce Dr. Thompson. Dr. Thompson is a well-known expert in the field of women's health. You may have seen her on one of our local TV news stations, where she frequently provides expert commentary. She received her postgraduate training in obstetrics and gynecology at Harvard-affiliated Brigham and Women's Massachusetts General Hospital residency program. Dr. Thompson's special areas of professional interest include young women's health and helping women of all ages to make empowering choices. We are so fortunate to have her with us today. Welcome, Dr. Thompson.
Thank you so much for inviting me, and thanks to all of you who are sticking around after lunch. I hope that I will earn your attention. I'm going to go ahead and share my screen. So give me one sec, let me get that. Okay, I hope everyone can see my screen okay. Awesome. So this afternoon, we are going to talk about trauma-informed care, which some of you may be familiar with. This may be new to some of you, and it's an important healthcare approach that every provider of healthcare, no matter where you greet patients, should know about, but it's not my favorite, and I'll tell you about one I like better. And so let's begin. Just housekeeping in terms of disclosures. I don't have any relationship with any commercial entities. Sometimes I wish I did. And then in terms of an agenda, there's a little preamble. Then we're going to talk about the learning objectives for this session, a definition of trauma, what is trauma-informed care, why this is important, or the epidemiology, and why it's not the one I prefer and an alternative. And then at the end, hopefully we'll get a chance to go through some clinical vignettes. I think we'll have time for that. So in terms of preamble, this topic may make some folks uncomfortable. And if it does, remember, whenever you're in a circumstance where you feel discomfort, when you're what young folks call triggered, right? That's pointing to an area of growth for you, an area that needs perhaps healing or needs some extra care. So I want you, if that happens during this session, to take some time to sit with that discomfort and think about what is it that you might need, what are the circumstances or the tools or the treatment that you might need for your healing, for your growth, for your learning in this area. And hopefully you'll find some of that in this talk this afternoon. All right, so let's talk about learning objectives. By the end, hopefully everyone will be able to define trauma and define adverse childhood events, understand the epidemiology, so how often these occur in the population, list some principles of trauma-informed care, and understand, again, why it's not my favorite. What are some of the limitations and an alternative approach to thinking about care? So definition, lots of definitions of trauma, of course, like every other word in the English language. This one is from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And they define trauma as a series of events experienced as harmful or life-threatening that can have persistent adverse effects to physical, mental, social, emotional, or physical, or spiritual, well-being. And then there is what we've all heard of is traumatic stress, right? We've heard of lots of folks who talk about being diagnosed or worried about post-traumatic stress disorder. And that is persistent reactions following adversity that can overwhelm your ability to cope. So that could be nightmares or flashbacks or being triggered and then feeling like you're in a situation where coping mechanisms that might have worked in the past are not working now. So those are two definitions that are important as we go on. So the epidemiology. There's so many studies that show that virtually everybody experiences one or more traumatic events in their lifetime. So trauma is exceedingly common, and study after study over many decades have shown that. There was a big collaborative study between Kaiser and the Centers for Disease Control, where 17,000 of Kaiser members who were appearing for their wellness exam, their annual exam, were surveyed. And the key is highlighted. Over 2/3 had at least one traumatic event or adverse childhood event. And studies show, unfortunately, that over half of traumas occur in childhood. And these have been termed adverse childhood experiences. So how do we define those? Potentially traumatic events that occur in childhood, and they can be varied: experiencing violence, abuse, neglect, witnessing violence in the home, or having a family member attempt to die by suicide. These events not only we defined traumatic or adverse childhood experiences not only by violence, but also by events that undermine a sense of safety for a child, or a sense of stability, or even bonding. So adverse childhood events can come from active experiences like violence, but also from neglect as well. Traumatic events can be emotionally painful and distressing, and as we know, the effect of them can persist for years. There are factors that can mitigate adverse childhood events or traumatic events, and that is the frequency or seriousness can make them worse, or if a child has good social supports or good familial supports, that can help mitigate the effects. And then this slide just points out that there's a big diversity in terms of the events that a child can experience as adverse or traumatic. Emotional abuse, and it gives you some indicators of the prevalence there: sexual abuse, physical abuse, to neglect, parental divorce, mental illness, etc. And some of these events are not intentional. So if your mom is schizophrenic, she's not intending to harm you, but a child can experience that in an adverse way, depending on the supports that are available for that parent or for the child. And this slide has a lot of words, but basically what it's demonstrating is that trauma and adverse events affect the maternal health space as well, because of course women represent the general population. One study looking specifically at post-traumatic stress found that 20% prevalence in a maternal care population. And that's, significant, and definitely makes this a topic that's so important for all maternity care providers to be aware of. And then another study in Britain found that, again, reflecting the Kaiser study, 60% of women, 61% reported at least one traumatic event. There have been a lot of studies that have linked and found correlations between maternal trauma or maternal adverse childhood experiences and perinatal outcomes. Now, let me pause and say that correlation is not causation. That does not mean if you have a trauma, you will, of course, suffer perinatal trauma or adverse perinatal event. But it definitely shows that there's overlap between the two populations. Another area that I don't focus on in this slide, but that there's a wealth of data on, are traumatic experiences that happen during pregnancy, during birth, because of course, pregnancy can be uncomplicated and have happy, healthy mom and baby. And then pregnancy can result in complications that are unexpected for mom and for baby. And so those can be experienced as trauma to women as well. So that's a whole other area where traumas can arise in someone's life. And so trauma-informed care really is a philosophical shift. And it's a shift from the traditional question that can be posed in medicine of what's wrong with you, what's wrong, what's broken, what's going on, what needs to be fixed, to what has happened to you. And those questions are not necessarily mutually exclusive, but they do represent a shift in approach. And I want to pause here to talk a little bit about the history of medicine. This is not a talk about the history of medicine, but it's important to keep it in mind as we think about this shift in perspective. So if we think about medicine 200 years ago, 100 years ago, the medicine, and I want to clarify, I'm talking about Western medicine, allopathic medicine has been handed down to us today, was the province of wealthy, powerful white men, right? And those wealthy, powerful white men definitely had a perspective on the world. And their perspective was, I am knowledgeable, I am at the top, you were less knowledgeable, you were not at the top, right? And so that hierarchy is reflected in the medicine and the way medicine was practiced. So it was a very much, the model is white male perfection, the model of knowledge and health, and the model of who needed help were people who were less than. Their knowledge was inferior if they were thought to have knowledge at all. Now, as medicine has changed, as there have been women admitted to medicine, there have been Black people and Native Americans and people of color and LGBTQ, as those populations have come into allopathic medicine, they bring their lived experience with them. They bring the knowledge of who they are with them to medicine. And that knowledge is shaping and changing the body of medicine, as you will. And so it makes sense that we're making the shift from what's wrong with you to what has happened to you. Because as those populations come into medicine, come into the body of knowledge, they are bringing a wisdom that says, we are not broken, right? We are not less than. We have knowledge that is valuable too. And so we start to see those populations and their perspective shift the big body of medicine, if you will. And this is an example of that. So moving from what's wrong with you to what's happened to you is a reflection of those perspectives entering the profession. And so let's talk about some principles of trauma-informed care. Well, there's 6 basic principles. And one of them is very basic, right? It says that the places and spaces where you show up for care should be physically safe and they should be psychologically safe. You should not have to worry that you will show up in a space seeking care and be harmed. Now, is that perfect? Absolutely not. I always say every place has culture and medicine has culture too. So you will find people who are dedicated to principles of healthcare, and you will find people who are not, even though they're in that space. But trauma-informed care says you should find safety where you show up for care. Another principle is trustworthiness and transparency. So you as a seeker of care, may not have the same knowledge of how the human body works or of public health, but you should be able to understand the process of your care. That should be clear to you. And if it's not clear, a few questions should clear it up. You should expect that you can ask questions about your care and that you will get answers that make sense to you. There should not be secrets about how this thing works. There should be no man behind the curtain, right? The curtain should be clear. You should be able to see behind it and understand what's going on. So peer support and mutual help is another principle. Collaboration and mutuality. Again, you, the seeker of care, and the provider of care are in a collaboration to solve your problem. You should not come and find that there is, the provider who is almighty and above, and the seeker of care who is below. Trauma-informed care says, no, there's mutuality. There might be a difference in knowledge. There might be a difference in access, but there's not a difference in terms of that collaboration to heal. Empowerment and voice and choice. Again, you as a seeker of care should know that, should be welcome to express your preferences, express your voice, express your advocate for yourself, because you have equal standing, you have equal power to ask questions, to state your choice, whether or not it's the recommendation of the care provider. So that's a key component of trauma-informed care. And finally, that cultural, historical, and gender issues not only are paid attention to, but that those perspectives inform the care that you're getting. And so that a principle of trauma-informed care is that we move away from that hierarchy that I talked about earlier and move toward one where other perspectives are valuable and other perspectives are looked to for solutions, in addition to being seen as, oh, these populations have problems, but that's where solutions arise as well. Oh, sorry. There we go. And so I personally value a trauma-informed approach, but there are a lot of reasons, and I'll go into them in a moment, why it's not the approach that I tend to use, although it informs my thinking. And I think trauma-informed care is a valuable approach to inform healthcare, but I don't think it should be the dominant one that we use. And let me talk about why that is. So the first reason is the first thing I talked about. Trauma and ACEs are exceedingly common. And I think that the assumption should be that the person in front of you has at least one, because that's what the data shows. And therefore, all healthcare environments should be healing environments, regardless of whether you acknowledge a particular trauma. So regardless of whether you already know that the person in front of you is positive for one ACE or one example of trauma, the basic healthcare environment should be designed to handle folks who have one, because the data shows that they do. Also, a trauma-informed is a focus on the negative. So care imitates language. I'm stealing that quote from someone and I forget who, but the general healthcare approach should communicate the behavior we want, not what we don't want. So I talk about a healing approach or a therapeutic approach, which is informed by a trauma-informed care approach, but doesn't put trauma first, because we want to put the thing that we want first, the healing or the therapy. And many implementation models in terms of trauma-informed care advocate universal screening. And I am always hesitant to screen for something where I don't have a follow-up. And we know in this country that mental health care, sadly, is neglected. In many parts of the country, Arizona being one of them, mental health care is a high needs area. Our entire state is a high needs area when it comes to mental health services. So often the services that we would then refer someone to after we've identified a trauma is lacking. And then when we start looking at care that matches someone's cultural or other identifying background, LGBTQ, Black, Native American, whatever it is that they choose, that's even more lacking. And so I'm always hesitant to screen for something when I don't have an appropriate follow-up or one that someone can access easily or affordably. Again, trauma-informed care for me emphasizes injury and can overlook recovery, resiliency, grit, and growth. Many who experience trauma not only show incredible resilience, but actually can thrive in the aftermath. So if I'm screening for trauma, am I also screening for recovery? Am I also screening for growth? Am I also screening for resiliency? Because some studies show that over half of folks who experience trauma, whether it's an adverse childhood event or later, rebound and grow and recover from that. So I find that part limiting. Clinician behaviors that avoid re-traumatizing are not the same as, and maybe opposite of, behaviors that promote healing. Part of the literature around healing from trauma talks about conscious re-experience. So avoided behavior after a trauma can often exacerbate the effects and the adverse effects of trauma. And to heal, oftentimes you want to re-experience, but in a controlled way, not in a way that is re-traumatizing, obviously. And so sometimes clinicians will need to re-expose or even acknowledge a trauma, and that might be seen by some as potentially re-traumatizing. But so therapeutic behaviors can sometimes look like they're re-traumatizing behaviors when controlled. Obviously, I'm not recommending willy-nilly and without thought exposing someone to a traumatic experience or bringing up a traumatic experience. But sometimes clinicians have to do things that look like they hurt to get to healing. And then finally, trauma and ACEs can be not remembered. So even if I screen you, you may not remember that that happened, but nonetheless, the trauma and the response to the trauma are baked into who you are, even though you don't recall it. It may be denied. Someone may not be in a position to admit that they have been the victim of whatever the situation is, or they have experienced whatever, because it's so raw, because it's so fresh. They're still having the effects of it, but they're not ready to admit it yet. And oftentimes I find in my clinical experience that trauma and ACEs show up in ways that might be surprising and that may not be recognizable as the effect of a trauma. And we'll get to some of those hopefully in some of the cases that we'll talk about. So my approach is that it is very important to learn a trauma-informed approach because trauma is common. We should be developing therapeutic environments, clinical environments that use the approaches that trauma-informed care recommends and finds as basic principles. But in terms of implementation, we want to talk about healing. We want to talk about being therapeutic because that is the outcome that we want, both for our patients who come to us and for the staff who we're working with and who are working with those patients. So let's talk about principles for the healing or therapeutic approach that I talked about. Now, everything on this slide actually are principles for implementing trauma-informed care. The reason I put them on this slide in the healing therapeutic section is that these are universal principles. These are not unique to a trauma-informed approach. These are principles that should underlie any healthcare environment, whether it's the orthopedic surgeon or the ENT or the general surgeon or the OBGYN or the pediatrician. An environment that's physically and psychologically safe is basic. Using harm reduction strategies, shared decision-making, individualizing plans of care. So you may have templates that you use, but how do they apply to this person in front of you right now? What aspects fit, what aspects don't fit? That should be true for all care. Limiting distractions and stress and being fully present. That should go without saying that a provider should be fully present in the room. And I know in the technological age, we have these laptops, we have these iPads, and your clinician might carry it around, but that's no excuse for focusing on the equipment versus the person in front of you. And allowing time for feedback from patients. Again, most clinicians are under significant time pressures, but that doesn't stop you from either answering the question today or setting up a time at a later date where you can make sure that questions are answered, that the person coming for care understands exactly what was done today and what needs to be done in the future. That's part of the deal of being a provider. And then let's talk about some principles then, some general principles of a healing approach, just like we talked about the principles of trauma-informed care. And these are Dr. Thompson's principles. You might not find these in a book, but these are principles that underlie that healing therapeutic approach that I was taught when I was in medical school. So no human being is beyond the reach of human empathy. What do I mean by that? Meaning someone may have all sorts of behaviors that society deems as bad, or like the women in that video we saw, those of you who are here at lunchtime, they might be abusing a substance, or they might be homeless, or they might be making choices that we deem not healthy for their babies, etc. Regardless, when that person comes for care, they deserve to be listened to, as those women in the video said, without judgment, with empathy, and they deserve to be treated with kindness, even if at the time their behavior might not be kind. As the provider who is stable, who is in a position of power, we have an obligation to be kind and to listen without judgment. All human beings want to be well. Again, regardless of what situation someone's in at this moment in front of you. One of the big lessons that I remember from medical school and has been so powerful for me over these many years is that every behavior, even behaviors that look like they're self-harming, that look ineffective, that look dysfunctional, these behaviors are being done to make something else better. Because humans will not seek to harm themselves because they want to hurt. Humans always want to feel better. They always want to be well. And they're doing that behavior that seems like it's hurting, that seems like it's destructive, to make something else better. That something else may be the voices. That something else may be a feeling of anxiety. That something else may be a feeling of despair. But they're doing that behavior to make something else better. As a clinician, our job is to figure out what that something else is, and also to help them come to a place where they can do something that is less destructive, more beneficial, to get to that good place, to get to that feeling of better. An individual has the right not to follow good advice. So oftentimes as clinicians, we feel like we're giving great advice. We are correct, we are right. And so how dare they not listen to what we're saying? But as sentient human beings with self-efficacy, we all have a right not to take good advice. You remember being 17 and 16 and 15. Your parents were likely giving you great advice, but as an independent human being, you were not in a place at that point to agree that that advice was good, and you had a right not to take it. So do people seeking care. And even when you may experience harm, you and patients deserve the right to refuse. Teaching and talking are an integral part of healing. That means answering the questions. That means explaining again. That means saying it in a different way. Those are all parts of trying to solve a problem for someone who is looking for a solution. But there's no perfection. I will get it wrong sometimes. The person seeking care will get it wrong sometimes. And we both have to recognize that that's going to happen, and both be willing to both apologize, admit when you're wrong, and move on. Let go of the past and move on. Healing is independent of moral values. What I mean by that is, it doesn't matter if you're Democrat, Republican, pro-choice, anti-choice, married, single, multiple partners, have a fetish. These things don't matter in terms of, I have a problem, I'm trying to find a solution. And so those values don't matter. It's interesting, we're seeing this outbreak of monkeypox right now, and there's some who are very dismissive because gay men are getting monkeypox. Monkeypox is a virus. It does not care who you are. It doesn't care what your values are. Just like COVID did not care, just like H1N1 did not care. Healing, breaking a leg doesn't care about what your values are. It doesn't matter if you're religious or non-religious. It doesn't matter what religion you are. These things can happen to everyone, and everyone is worthy of help, no matter what their belief system is. Clinicians have a different expertise, not a better expertise. And what I mean by that, again, talking about 200 years ago, right, the way medicine was seen then, they really thought that their expertise was the better one. It was the only one. It was the one paradigm that was primary and nothing else mattered. And we know that, we have one expertise. Even Western medicine is a particular way of looking at disease and wellness. There are other ways of looking at disease and wellness. And while Western medicine may be great at X, Y, and Z, another way of looking at disease and wellness might be better for A, B, and C. So it's a different expertise, not necessarily better, or not necessarily better in all things. Might be better in some things, and some other ways of looking at the world might be better in other things. Clinicians are in a position of power in terms of access and information, and have a different responsibility. And what do I mean by this? I'll give you an example. There is not a trend, that's the wrong way to put it, but a way of thinking in medicine that says patients have a right to autonomy, and therefore clinicians should just do what patients say they should do. Right? So someone comes in and says to me, let's say a 20-year-old comes in and says, I want my tubes tied, that I should just say, yes, go ahead and tie your tubes. Now, there's some truth to that. There are her tubes. At the end of the day, if she wants to tie them, she can. However, as a clinician, I know things that she does not know. And so I have a responsibility to make sure that she knows what I know, and that she understands that there's lots of data out there that says women who tie their tubes before age 30 have a high risk of regret. I have to make sure that she understands that. I also know that there are not lots, but there's several methods of birth control that are as effective as tying your tubes. They're not less effective, they're as effective, and they give you the option for reversal. So it's my job to make sure that she knows that. So it's not as simple as, if they're her tubes, go ahead and tie her tubes when she's 20. Because if I don't make sure that I share that information with her, I've done her a disservice. So my responsibility is different because I have access and information that she does not have. So sometimes it's complicated. It's not as simple as it might seem. And even though social media might say otherwise, my responsibility is still the same, because I still have the power and the access that I have. And sort of corollary with that, clinicians have a wealth of knowledge about bodies in general, but we should not forget the individual in front of us knows about their body and their experience the most. So even though I know things about science and medicine and data and studies that she may not know, she knows things about her experience and her body and what she feels that I might not know, that I definitely don't know. And so my job is to elicit from her those details and not to be dismissive of them, not ask about them, to listen to her story and then help her combine what she knows and what I know to try to come up with a result that's going to work for her. So this was a lot on one slide, but I wanted to give you a perspective on trauma-informed care, which is definitely important. I can't stress that enough. But how we can take what trauma-informed approach teaches us and make that universal to principles that we can apply and provide good care, regardless of whether we know about someone's trauma or not, regardless of whether we screen for trauma or not, because sometimes we may not get that history, even though it's there. So I'm going to stop here and we're going to take some questions if there are questions in the chat, and then we'll go through a few cases and talk about those. I'm going to stop share for a second. And let's see if there are any questions in the chat, and I'll go through those. And if not, then I'll share again and we'll go through some cases.
We have not really received any questions per se. We're getting lots of feedback about how great this presentation is.
Oh, thank you. Good. I hope it's helpful. So let's do this. I'll share again, and then I have a whole lot of cases, and I can talk about how trauma can show up, especially in the OBGYN setting, obviously. Those are the patients I see, because sometimes it's not the way that you think it is. So let me go ahead and share again, and then we'll go from there. And please, stop me from talking when I'm out of time.
You got it.
Okay. And I put these cases in Spanish and English because I added them last, and I felt terrible for the translators. So hopefully my Spanish translation is correct. I understand Spanish a little bit, so I checked, but I hope if someone who speaks Spanish, please correct me if I got something wrong. So the first case is of Desiree, who's 4 weeks postpartum. She's called the office 3 times in 1 week complaining of abdominal pain, but she's refused every appointment that was offered to her. She's often angry during her calls, accusing staff of not wanting to take care of her. And I will tell you before we start talking about Desiree that these are not made up. These are they might be a composite, but these are all cases that I've seen. And this one, the call that you get or the calls that you get of someone who has a complaint, and they may be crying, they may be upset, but then they don't come, they either refuse the appointment or they don't come to the appointment. But when they call, they're in distress. And this is one of the ways that, that you have to ask yourself, what happened to you? Instead of what's wrong with you and get angry or upset or, say, I'm not going to schedule another appointment for her. These might be some of the responses that clinicians have, right? She's disrespectful. She's no-showing too many times. She is obviously attention-seeking. That's another one we hear, right? So, and we haven't screened her. We don't know anything about her traumas. In fact, she may have denied that she had any trauma before, but now she's delivered a baby, which is its own transition. For those of you who've ever been through pregnancy and childbirth, it changes you. And so now her trauma might be manifesting. And so what this takes is let's go back to those principles I talked about, right? You have to remember about empathy. You have to be kind, even when she might not be kind. And you have to say, hey, how can I help you? What might be going on for you? So you have to remember these principles in order to get past the barriers she's putting up. Because sometimes trauma will show up as putting up barriers, right? A barrier of anger, a barrier of tears, a barrier of not coming in, a barrier of missing appointments. And so it's so important to recognize that trauma doesn't always show up like the neat examples in the books or in the articles. When I was researching for this talk, there were so many articles that gave examples of trauma, and it was always, Janet is 42. She's a refugee from Syria. She saw violence as a child. It was always very obvious what the trauma was. It doesn't show up that way. In practice, it is rarely the Janet who is a refugee from Syria, not to diminish that experience, but what I'm saying is it often does not show up that way. So let's talk about another one. Oh, I thought I translated this one. I apologize. So Jackie is 24 years old. She's in labor with her first child. During labor, she frequently responds with suspicion and hostility to minor inquiries from the care team. During one pelvic exam performed at her request, she began to scream and cry that the physician was raping her. And again, this actually happened. And this is a more obvious example, right? Clearly, something had happened to Jackie in the past that now she is reliving. But again, you have to remember when this happens. And when this happened, the resident who was taking care of her at the time was very upset and taken aback and disturbed. She was very upset. She's like, oh my gosh, what is happening? I'm being accused of assault, which is a serious accusation. And she didn't know how to handle it. Why? Because she wasn't taught about a trauma-informed approach, right? And that's why this approach is so important to teach, to have trainees understand that trauma is going to show up in your work. And it may show up subtly, like Desiree. It may show up more obviously, like Jackie. But it's still important in that moment to remember empathy. To remember that even though Jackie in that moment is being accusatory, is being angry, is being hostile to the care team, Jackie still needs and deserves care. And so how do you approach her in that moment? How you have to calm your own emotions. And that's one other important thing about a trauma-informed care approach that I didn't talk about in the body of the talk, but in implementation, they talk about training staff. And that is so critical because as we take care of folks who have trauma, 2/3 of us might have had trauma ourselves. So it's so important to be able to have tools that help you, the care provider, not be triggered, not go to that place where now you're acting out of your own trauma and unable to respond to the person who is seeking care. So it's so complex and complicated, but as providers, we have an obligation. Remember I said, we have different access, we have different power, so our responsibility is different. And so to remember that in a situation where someone's being hostile, where someone's being accusatory, we have to take a moment, get ourselves together, because that's often necessary to tamp down our own responses to our own traumas, to tamp down our own mirroring of bad behavior, because humans have mirror neurons. And mirror neurons are the part of our brains that when we hear someone playing piano, it's as if a part of us is playing piano also. When we hear someone screaming and being hostile, part of us is screaming and being hostile too. And it's very easy then to respond in that way. But we have to, as providers, remember that we have a different power, we have a different responsibility, and to then be calm and respond with empathy, respond with kindness. Any questions so far? Because I can go on. I have many of these. Oh, you're on mute.
Sorry.
Jeanette.
I'm having a little trouble with that today. No, there's not particular questions to your presentation.
Okay. So I'm going to keep going. Whenever you have a question or a comment, or just drop it in the chat because we're paying attention to the chat.
We are.
Here's another one. Jasmine is 18 years old, pregnant with her 4th baby. She dropped out of high school when she was pregnant with her first baby at age 14. Now you can imagine the question, what happened to you? Most 12, 13, 14-year-olds are not thinking, what I'm going to do is have a baby and drop out of high school. 12, 13, 14-year-olds may not like school, right? They may love babies, but what most of them are not thinking about is, I'm going to make one. So when you see a young girl who is pregnant or even sexually active, you want to ask what happened to you. Now, she may be the outlier who nothing's happened to her. She's perfectly functional. But you definitely want to ask the question. You definitely want to ask Jasmine what's going on for her. You definitely want to ask Jasmine about Jasmine and not just about the baby she's growing now or the ones that she has. You want to ask Jasmine, what are your hopes and dreams, Jasmine? Do you want to go back to school? How can I help you do that if that's your goal? Because what often can happen is that young women start having babies, and then everyone, the whole world, focuses on babies, childcare, childhood development, her parenting, her value as a parent, and forget to continue to focus on Jasmine. So we have to continue to remember that Jasmine's still there, even though she's pregnant, even though she's had babies, and regardless of what we think about the quality of her parenting. Not to say that that's not important, but that's not the only thing about Jasmine. And perhaps sometimes if we pour into Jasmine, she will be, not sometimes, every time, if we pour into Jasmine, she will be able to be a better parent to the children she has. Also, the world can get very judgmental of young people like Jasmine. Oh, she's 18, she only has 4 kids. Oh my God, she doesn't have a high school education. Instead of looking at how can we serve Jasmine? How can we make sure that she's meeting her goals? How can we make sure that she's the best parent she can be if she's interested in parenting? Let's go on. I could go on and on and on. Kate is a 13-year-old who's pregnant with her second child. Now, this brings up issues not just for Kate, but what's happening with Kate's parents? Kate was pregnant with her first child at age 11. Now she's pregnant with her second at age 13. What's happening at Kate's house, right? Where are her parents? I will tell you, this case was very interesting because I had those questions when I saw Kate. And so I called CPS, not necessarily to report Kate, but to say, hey, what's going on? And they said, well, interestingly, you may or may not know this, that if the father of the baby is within 2 years of the young girl's age, then it's not statutory rape. That's how it's defined in our state. And I said, well, I wasn't calling about him really. I was calling about her parents, right? What's happening in Kate's house that at 11, she has the privacy or the time, unsupervised time to have sex and get pregnant. And then again at 13, where are the parents? Where are the folks who are supposed to be giving Kate a stable home, care, who's supposed to be there supervising Kate, making sure she goes to school and is groomed? And what happened with those parents? What happened with them? And then there's Kate herself, right? How is she experiencing, or how did she experience being pregnant and having a baby at 11? How is she processing that? Is she getting what she needs to make sure that she's continuing her development, both physically, mentally, psychologically, because she's still only 13, and trying to be a parent now of 2 at 13, right? So there's so much there in terms of thinking about Kate and what she lacked in terms of parental care and guidance, and also to help her be the best parent and to provide that parental care and guidance to her now 2 children, even though she's 13 herself. So this is how trauma shows up, though. It, again, might not be that woman who's been battered for 13 years. It might be Kate.
We have a question for that one.
Mm-hmm.
It says, is it appropriate to get Kate on birth control?
Absolutely. And I think Kate is probably like 23 now or something. This happened a while ago. And so we talked about that. We talked about both during the pregnancy, we talked about what would you want to do to prevent getting pregnant again. And we talked about it in the sense that Kate agreed 2 kids was a lot to have when you're 13 or 14 by the time she delivered. And so what do you want to do about that? And we talked about the pros and cons of different methods for a 13-year-old, right? So methods have effectiveness, but they also have effectiveness based on being used correctly. And what methods could a 13-year-old use correctly, given that you now have 2 children, you're going to try to go to school, et cetera, right? So we talked a lot about what her goals are, what her circumstances are, and what she could use effectively. And she did use birth control, and she did not have, and I don't think still doesn't have, if I remember correctly, any more children.
There
So
was,
it was a good conversation, and it was shared decision making.
that's great. There's another question on that. Now,
Mhm.
Emily Jordan is asking what type of birth control works for a 14-year-old and that won't cause problems later on in life.
The truth is any and all. So any form of birth control will work. One of the things that it's hard to wrap your mind around, especially in this age time now we're living in, where there's a long adolescence, is that when a young woman starts menstruating, that is an adult body. Her body, by definition, is an adult body. So at that point, whether she's 10, 11, or 12, any form of birth control that a 30-year-old could use, she can use, because puberty is your body saying, I've moved from childhood to adulthood. So that's the first basic one. And then the next question will be then, what form of birth control can a 14-year-old stick to? Right? So that becomes the bigger question, not about health and safety, but about what can they use effectively. And the long-acting methods tend to be better, just because, again, if you're 14 or 15, even if you have no children, even if you're just in high school, right, you are might be in clubs, you're going to friends' houses, you're social, you're going out. So a birth control pill may not be the best method, not because you're irresponsible, but just because your life is one where stuff is happening. You're going different places, and where's that pill pack? Did it come with you to your friend's house? Did it come with you on a school trip? Or oops, is it back at home? Now, that may be true of a 40-year-old too, right? People can have busy lives, but that's one of the considerations, what works for you. Now, the only method of birth control that would give folks hesitancy in an adolescent would be Depo-Provera, the injection. And why is that? Because we know that Depo-Provera affects bone mass. It affects how your bones are. And since adolescents are still building bone, so our bones reach maximum maturity around age 30, you might hesitate to give an adolescent Depo-Provera. Although studies show that when you stop Depo-Provera, your bone mass replenishes in a fairly short time. So that might be the only one that some folks might hesitate to give in an adolescent. Although in this circumstance, let's keep talking about Kate, a 14-year-old who has 2 children who, for whatever reason, let's say no other method will work. Well, now you're going to weigh the risks and benefits for her of maybe some short-term bone loss over the risks and benefits of another pregnancy, of a 3rd child, right? So now you're going to weigh those risks and benefits and decide, does the benefit of giving her Depo-Provera outweigh that small risk of temporary bone loss given the risks of pregnancy? So that's sort of how you think about it and talk about it with the patient. Any more? You're on mute.
My dog barked and I had to turn myself off again. Sorry. Any suggestions of how to persuade other OBGYNs that these topics are worth their time to learn about and consider changing their practice? We continue to struggle with some providers who shame pregnant women and ask that question of what's wrong with you?
Yeah, that is an excellent, outstanding question. I will say that some of the changes that need to be made are not at the individual level. And some of the places where you can have the most impact are not at the individual level. And why do I say that? An individual clinician is seeing 20, 30 patients a day. They are under the pressure to provide good care, to do follow-up, to document. They're under financial pressures, right? They may be very resistant to new information, to things that change their workflow. However, where you might have more influence on them are places that change those dynamics for them. So who can change dynamics for that individual clinician? Payers, right, can change dynamics. So influencing a payer, you may have more opportunity to influence what the clinician does, because they can say, hey, in order for us to reimburse you, you have to do X CME. For example, this is actually another influencer, which is licensing boards. The licensing board for Arizona just said this year that in order to be licensed, we have to do CME on opioids. I don't have a choice, right? So that, regardless of what my personal feelings are, now I have to do that training. And so I can resist all I want personally, but I'm gonna go do that training because I need to get my license. So that may be a better place. Licensing boards, board certifying organizations, payers may be better places to influence the incentives that govern that individual provider's day. Because in their individual day, they may have too many burdens to even think about, sometimes even when they're willing to do something different. The other thing is that, like I mentioned, the history of medicine is one that is very hierarchical and very shaming, right? It was about, I know best, my values are better than your values. That is shifting though. We're seeing a shift in that. So I would bet you, as you get away from those sort of identities that shaped medicine, the white male, right? You get farther away, you get to women, you get to more people of color, your job will be easier. And as those people enter medicine more, the entire enterprise will be changing. But you're right, it is still an uphill battle in many places and spaces. But trying to influence the influencers might be easier than trying to influence individual clinicians. So think about the medical boards and the payers and the certifying boards, because they are shaping the day for that individual clinician. It's a great question.
Okay, I just keep getting all these. This presentation is awesome, but there is a question in here. One person said, don't forget that a lot of these girls have pediatricians and that they have a relationship with them. So as pediatricians, it is on us also to get more comfortable with expanding birth control access for our patients and providing
For sure
in our pediatrician's office. I thought that was a good comment.
That is exactly right. And this, so when I talked about a healing therapeutic model of care across the board, in fact, pediatricians are pretty good, right? Where we see doctors fall down a lot is other specialties. So for example, I had a patient with a brain tumor, right? She's diagnosed with a brain tumor, and her neurologist should have talked to her about birth control, because you're giving her a diagnosis that you say will require these particular treatments, chemotherapy, things that could, but you neglected to mention, hey, so let's talk about birth control, because what you wouldn't want to do is get pregnant in the next year while you're going through treatment, because that will impact your treatment. Or orthopedic surgeons who a pregnant woman breaks her leg, or a 13-year-old and doesn't talk to her about, hey, what birth control are you on again? Right? So you're right. The pediatrician's so important, and pediatricians are great because they actually have long-term relationships. So that's a great place to have an influence that can have a big impact, because they see people over years, right? And it's a trusted environment. Even if you don't know that particular doctor, when you go to the pediatrician, you're already in this place where you're expecting to trust. So influencing pediatricians can have a huge impact, just like primary care doctors, OBGYN, family practice, right? We have long-term relationships. But this should be true for every provider in every space, because even if you're in a specialty where you think, I don't prescribe birth control and pregnancy will crop up because women are everywhere. So yes, that's a very important point. Thank you for raising that.
I think you'll like this comment. It says, I sent Dr. Thompson a direct message, but I'm unsure if she can see them. I realized why she seems so familiar to me. She actually was my OBGYN that delivered my first baby 15 years ago.
Hey. Hey. Nice to see you, even though I can't see you. And thanks for reading that, because I will look into DMs after, because I'm sharing screen, so I can't see anything.
Okay.
Thank you. Do we have time for one? Let's see.
We've got until 2 o'clock.
Let's see what I've got.
I want
All
to
right.
stay in touch with you, and you can let me know how you're doing with getting neurologists to talk about birth control. That sounds
Oh
hard.
boy. Not easily, not easily, but they need to. Same for cardiologists. Same. I see women all the time who saw a specialist who should have talked to them about
Right.
contraception and did not. And you know what happens? Women get pregnant.
I know.
Especially, like, think about this. If someone gives you a diagnosis that is dire, or they tell you you're going to die, what are you going to do? You're going to go out and have some fun. And you're not going to be particular about where you have it. Your prognosis is that you're not going to live. And here's the thing, people live, and pregnancies happen in the meantime. And so actually that woman I mentioned, she had a baby and she's still alive. I think her baby's like 10. So doctors
Oh
can be wrong
gosh.
when they tell you you're going to die. And so, yeah. So let's do one more because we have a few more minutes. So Dolores
Okay.
agreed to undergo a procedure, needing a minor procedure that she needed, but she had a history of opioid abuse. So she said, I don't want anesthesia. And we made a plan. During the procedure, she reported pain and the procedure was stopped. But she filed a complaint with the medical board accusing the provider of abuse and torture. Again, this is an example of how trauma shows up, both as the opioid use and as accusations and as, misrepresentations. As this is how it shows up. And here's the thing, it's hard to have empathy in these situations, right? It is exceedingly hard. And that's why we have to take care of our own mental health as providers. But this is how trauma shows up. It is not cute. It is not just the woman who says, oh, please help me, I had trauma. That happens. But more often it's this. It's the person who is acting out, one, self-medicating their pain, and two, acting out of their pain. And, there's a saying, I don't know if everyone's heard a saying, but hurt people, right? People who are hurt will often hurt people. And what we have to resist is responding by hurting them back, responding by cutting them off from therapy, responding by cutting them off from empathy. This is where it's very hard to be a provider, because our responsibility is to continue to be healing, to continue to be therapeutic, even when what we're getting is accusations or abuse or vitriol. Because people are acting, again, not because they're mean or they want to hurt, but they're acting out of their own pain. Remember I said, people who, and actually I'll go back and leave us with these on the screen. People who are behaving in a dysfunctional way are doing that to make something else better. They're trying to make something else better. They're trying to feel better. And even though they're doing it in a dysfunctional way, that's what they're doing. And so it's so hard to remember to greet that with empathy, to greet that with kindness, to greet that with non-judgment. But that's what we signed up for. That's why we get the privilege and the power. That's why we get to be in spaces and to be witness to people's intimate moments and to see them naked, right? People come to us in vulnerability. And for that power, we have to remember to always lead with empathy, to not cut people off, even when they're not being kind or they're not being empathetic.
Well, Dr. Thompson, I have to say, you are amazing. And all of the
Thank you.
comments that we've gotten during your presentation support that assessment as well. So if I were you, I'd be expecting a lot of calls to speak in the near future.
Thank you. Well, I hope everyone got something out of it. I hope this has been helpful.
It's been very wonderful. Thank you so very much.